Risk and Reach report with the health domain deep dive this afternoon. We're excited to present to you a closer look at one of the 3 domains covered in the Illinois Risk and Reach report, specifically its health, and with attention to the latest that is happening with COVID-19 and the pandemic. We really wanted to draw some connections about early experiences and what we're seeing today. So first, I'd like to acknowledge our partners in this project. Erikson Institute partnered with the Illinois Early Childhood Asset Map and Voices for Illinois Children, specifically the Fiscal Policy Center, and Voices is now powered by the YWCA of Metropolitan Chicago, to put together this inaugural Illinois Risk and Reach report and fiscal scan. We also would like to acknowledge the support from our philanthropic community to ensure that this report, along with the fiscal scan and the interactive data website, was produced. I'm really excited to have our partner who really led the way in terms of drafting and pulling together all of the various fiscal data points. Mitch Lifson joined me today from Voices for Illinois Children. He's the Vice President of Policy and Operations. Given the comprehensive nature of the report, we had segmented out our workshops into really going deeper into the domains. And we started this before the global pandemic, but given the focus on public health with COVID-19, we resumed this through a webinar so that we can ensure that people really understand the origins of the acute health outcomes that we're seeing today. We will be flowing through this, first covering the risk and reach portion of the report that focused on health, and then Mitch is going to cover some of the highlights from the fiscal scan and looking at the fiscal year 21 budget. And then we will try to integrate some responses to questions that came up in advance of the webinar throughout this presentation. So first, I want to bring you up to speed with the purpose of the Risk and Reach report. And also the process. As you can see in terms of the purpose, it's really to ignite conversations, inspire action, and most importantly, provide this in a digestible and accessible way for policy and funding decisions. Throughout this production process, Erikson managed a multi-tiered feedback structure that convened an advisory council of more than 40 members representing key public and private stakeholders over the course of the report development, to collect and distill feedback on the operational definitions of risk, the data selection, the data analysis, the overall development of the report, and the dissemination strategy. In addition to the Advisory Council, Erikson convened regular meetings with early childhood stakeholders and advocates in the field, the Early Childhood Leadership Academy Fellow alumni, subcommittees of the Illinois Early Learning Council, and the Illinois State Bill team, resulting in the contribution of about 100 early childhood stakeholders throughout the process. Before we get into the report, I really want to just advance a particular consideration, something that the Advisory Council wanted to be really clear about is to disrupt the traditional definition of risk. Oftentimes when we frame, when we use the phrase at risk, it rolls off of our tongue really easily, and it's usually used to describe children, communities, and families. And the Advisory Council rejected that traditional definition and really wanted to highlight that risk actually exists in the environment. It's not inherent in children, families, or communities, and it shows up as structural barriers and systemic flaws that limit opportunity, choice, and conditions for young children to optimally develop and their families and communities to thrive. When we were putting together this report, we had in mind 3 different audiences. As you can see, we had elected officials and advocates and philanthropic leaders, as well as grassroots leaders in mind, in the various ways that they could use this information to inform policy decisions, programmatic decisions, and distribution of resources. I want to direct you to our website because that's really where you're going to find all the information with respect to this report. There is a print copy that you can download, but ultimately this interactive website gives you sort of easy access viewing of the data indicators. It's ideal for classroom lectures, planning meetings, funding presentations, public hearings, or if you're just like a data geek, you can nerd out with the visuals and tables. You can also download county one-pagers that give you a snapshot of all the indicators in your county, and you can toggle between county level data and legislative district level data when available. In the printed version of the Risk and Reach report, each of the 17 reach indicators is overlaid on top of the overall risk map, and I'll explain that a little bit later. But on the website, you have the option to overlay select reach indicators over select risk maps, providing more precise opportunities to explore the data. So for example, what you're looking at here is the underlying risk map here is childcare cost, and the reach overlay, which is the yellow dot, that's representative of the reach of the public investments related to childcare and the subsidy, the childcare assistance program. And you can also download the fiscal scan report, the full report that Mitch is going to be covering today. A lot of the feedback that we've received, it has really been wanting to access more precise data. We acknowledge that looking at data at the state and county level is kind of blunt and, may not tell the full picture of what is actually happening in your specific geography. And so I wanted to make sure that you knew where more precise data could be accessed, and that comes directly from our data partner, ICAM, Illinois Early Childhood Asset Map at the University of Illinois. And there you can find additional data that basically is able to really drill down from the state to the county to the municipality to postal zip codes to the Illinois State Board of Education and the Illinois Department of Human Services regional areas, additional legislative districts by state house and Senate and even congressional school districts, and then for Chicago, the community areas. So make sure to check out ICAM if you want to go even deeper and have a more nuanced look at the data. As far as today, what we're going to cover, we have 3 learning objectives. And, the first is to provide this deeper dive into the health indicators of the Risk and Reach report, and also draw some connections to the new Kids Count report that has been prepared by Voices. This is a little bit of a sneak preview. They will be releasing the full report shortly, but we saw some really interesting comparables that we thought would be helpful as well. But we also want to discuss the fiscal investments related to the health domain and connect that, to the budget process right now. And of course, all of this is going to have that COVID-19 spin, because that has become our new reality and how we digest information, and ultimately will influence a lot of our funding and policy decisions. So as stated earlier, the chronic underlying health conditions that present a greater risk for acute outcomes with COVID-19, they begin in early childhood and have direct connection to the manifestation of systemic racism and how it shows up as structural barriers preventing access to high quality health care, housing, and economic stability, as well as other social determinants of health, which we'll get into momentarily. And so what I want to be really clear about, though, as we go through this, is that we're not going to be interpreting the data today, because the report was designed specifically to ignite conversations at the local level and provide relevant child well-being data to policymakers, community leaders, and providers to aid in making program policy and resource distribution decisions at the local level. And so this webinar is going to show you how to read a map, how to look at a couple different data indicators together, and also how to have some discussions around the data. So we'll show you some discussion questions that you can take back to your community to contextualize the data and inform your decisions anchored in the expertise of your experience and your geography. So I mentioned the social determinants of health, and in the public health space, this has, been something that is very much anchored in that particular discipline. And essentially, the social determinants of health are the conditions in which people are born, grow, live, work, and age, as well as the complex interrelated social structures and economic systems that shape these conditions. And they include aspects of the social environment, such as racial discrimination, income, educational level, marital status, the physical environment, such as place of residence, crowding conditions, the built environment, that includes building spaces, transportation systems, and products that are created or modified by people, and health services, access to and quality of care, as well as your insurance status. And essentially, the social determinants of health are linked to the lack of opportunity and to the lack of resources to protect, improve, and maintain health. And taken together, these factors are mostly responsible for health inequities, which are the unfair and avoidable differences in health status seen within and between populations. I also want to draw something to you to consider with respect to what just came out of the Center on the Developing Child at Harvard University. This is a statement in which they kind of were able to really unpack how early experiences truly do make a difference. And you have certain conditions that children are born into and that their families are subject to that they didn't have any kind of control over. And some of these conditions can be threatening to health very early in life. So lack of access to nutrition and living in a food desert. That is a place where you cannot get fresh foods easily and readily available in close proximity to where you live. Exposure to pollutants and other environmental toxins. Excessive family stressors associated with poverty, with racism, and other forms of economic and social discrimination. Essentially, the structural legacies of racism and other cross-generational traumas are linked to levels of chronic stress that really make you more susceptible for certain health conditions. And what we are truly seeing right now with how it is playing out with COVID-19 and the disparate impact on particularly the African American, Latinx, and Native communities. So I wanted to make sure that you all had a chance to kind of see the questions that we typically provide communities and other stakeholders to spark these conversations that the data provoke. And these questions are just meant to kind of help guide you as you're looking at the maps and the differences, and can also really help to guide the conversation with various stakeholders. And so they're really meant to sort of be something, an introduction. Of course, feel free to develop your own questions and your own kind of analyses, but this is where we start whenever we are showing these maps to other stakeholder groups. And then if you really want to get into the equity-driven discussions, which are incredibly important when we're looking at distribution of resources as well as concentration of risks, this set of questions here really helps you focus so that you're intentional about racial equity and understanding who benefits or who is burdened by current policies and systems in place. And these, candid conversations on systemic racism are absolutely necessary in terms of how we devise solutions to really get at the root cause. Because ultimately, when you look at risk factors and you disaggregate them by race, ethnicity, the inequities are apparent and blatant, and they primarily affect children and communities of color. So whenever we do these presentations, we always kind of level set looking at the state of Illinois. So let's just start with some basic demographics of our state. There are 12.8 million residents living in Illinois. 61% are white, 17% are Latinx, 14% are African American, and 7% are categorized as other. I want to give a little bit of an explanation of the other category. So due to a lack of detailed data for certain racial and ethnic groups, Asian American Indian or Alaska Native, Native Hawaiian, or other Pacific Islander and 2 or more races are grouped into one category as other non-Hispanic. And our objective in future iterations of this report is really to break out other, because it doesn't help us to kind of homogenize such a heterogeneous group. But then looking at what our population breakdown and the demographics, how they shift, this is what it looks like for children age 5 and under by race and ethnicity, which is the population of focus for the Risk and Reach report. And it's really important to note at this point, all of this data is based on the census. We know that historically there's been an undercount of children, young children in particular, with the census. And that's why there has been such a big push for Census 2020 to ensure that every single individual is counted, irrespective of age, irrespective of immigration status. And there has been a huge push with our state to ensure that we are successful in this endeavor. But with that said, given that there's an undercount, these numbers are just estimates because they aren't really true and accurate of every single child in the state of Illinois. So the next piece I wanted to show you is related to children age 5 and under by household income. And you can see this is broken out. Each bar represents a different racial and ethnic group, and you can see what the proportion is of children age 5 and under living below the poverty level, which is 100%, or to kind of give you a sense of what that is for a family of 4, that's about $24,000 to $25,000 annually. And so you can now see the blue represents at or above poverty level, with the purple representing below poverty. And you can see the stark differences amongst the racial and ethnic groups. This next map shows the distribution of child population across the state. And this is also sort of a great template for you to get oriented to the maps within the report and on our interactive data website. This is a heat map that essentially in the bottom left corner shows you the color gradation. So the darker the blue, the higher the number of children age 5 and under, and the lighter, obviously less amount of children. So you can see sort of the distribution of where young children are concentrated across our state. And all of our maps will have the same layout with the title, the subtitle, the legend at the bottom, and the color coding to represent a particular data indicator. So because this is the health domain deep dive, just wanted to kind of review what health factors are critical to child development. First and foremost, supporting health and wellness in the first 5 years of life is just paramount. It really sets the stage for optimal growth in childhood and beyond. What we will see is that, consistent access to receiving vaccinations and screenings and preventative care and well baby visits are incredibly key for setting the foundation for healthy outcomes. Health also needs to be holistic and consider nutrition as well as mental health and well-being. And children's health is deeply connected to maternal health and exposure to risk factors in their environment and community. And what you'll see in terms of the indicators that we select really speak to all of these pieces. So first, we're going to start with the risk factors experienced by young children 0 to 5 in Illinois. And as you can see here, these are the 15 risk factors that the Advisory Council selected to comprise the Risk and Reach report. But today we're going to just focus on the health risk factors. And as you can see, there are 4 of them. And they were selected based on 2 criterion. The first is that they needed to be anchored in child development research, validating the indicator as producing conditions and circumstances that may compromise optimal child development. And then we also needed the data to be able to come back to us at the county level. So I'm going to take us through these 4 indicators so that you can kind of get an overview of what they cover. And so first we start with maternal morbidity. And this is actually a perfect case study on the importance of disaggregating data by race and ethnicity for 2 reasons. First, you'll notice that the majority of the state is shaded white, which indicates that there was no data available. And, that's partially because severe maternal morbidity is a rare outcome, and data were only available at the county level for 18 out of 102 counties. However, if it's such a rare outcome, it begs the question about why, when we disaggregate this by race, ethnicity, the data reveals that African-American moms are experiencing severe maternal morbidity at 102 per 10,000 deliveries. That is twice the state rate, which is 51. So this map shows how often severe maternal morbidity occurs per 10,000 deliveries. And that's what you see right here in this particular map. Now, there could be a variety of factors that contribute to the lack of data. But I really just want to put in here that severe maternal morbidity includes unexpected outcomes of labor and delivery that result in significant consequences to a woman up to 12 months postpartum. So note that this indicator does not include postpartum depression. Instead, it's focused on severe medical complications, and it is also limited to complications that occur during the delivery hospitalization before the mom leaves the hospital. And so ultimately, what this particular map allows for us, or this data, is really have some pointed discussions on defining severe maternal morbidity and data collection standards to align across our systems. And then it really sparks some questions on the role of structural barriers and systemic racism that contributes to these outcomes. So I'm going to now move us along to the next map, preterm births. And what you see here, preterm births are essentially infants born before 37 weeks of gestation. Statewide, it's 10.3% of Illinois infants were born premature. And premature babies often require longer hospital stays. They may also experience long-term cognitive and physical effects, including asthma, vision, hearing loss, intellectual disabilities, and other issues around behavior. And there's some factors that can elevate the risk of preterm births, including smoking, alcohol, drug use, domestic violence, very high stress levels, maternal depression, and prolonged work hours involving standing. And for many risk factors, adequate prenatal care is a really important intervention, and we'll see what that looks like on the REACH maps. But what you can see here, again, is another outcome when you disaggregate by race, is that African-American births are happening at a preterm more frequently than other births. And what I want to also point out when we're looking at this race and ethnicity data is that you'll notice that the percentages do not add up to 100% because we are looking within each race and ethnicity. So just for example, if we're looking at preterm births, within the universe of all African-American births, 15% of them are preterm. Lead exposure is another area, and this is essentially the percentage of Illinois children age 6 and under who were tested for blood lead and found to have elevated blood lead levels. And 3.5% of Illinois children aged 6 and under who were tested for blood lead were found to have those levels. So unborn babies, young children are more susceptible to absorbing and retaining lead, and prenatal lead exposure can affect brain development and can lead to premature birth, low birth weight. And childhood lead exposure can lead to headaches, stomach pain, challenging behavior, anemia, problems with overall brain development. Lead paint is the most common way children get lead poisoning, but some toys and other products manufactured outside of the country have been found to contain lead. It can also be found in contaminated soil and in water that flows through lead pipes or faucets. So, I mean, there's so many ways that we need to be incredibly careful about how lead is presented to young children. And as you can see, the exposure is different across the various race and ethnicities. Violence exposure, this is actually one in which this is a rate. We are showing the rate for violent crimes per 100,000 population. The state rate for violent crimes was 436 per 1,000 population. So this map isn't restricted to children 0 to 5. This is actually the universe. And we really wanted to be able to illustrate that violence exposure is prevalent throughout the state. It affects communities at a deep level. And ultimately, the cumulative effect of repeated exposure to violence is especially harmful for child well-being. And children exposed to violence may have some challenges with settling themselves, maybe have more exposure to toxic stress, which then results in difficulties with forming relationships. And they may present with regressive behavior, anxiety, depression, aggression. And so it's just really important to pay attention to the prevalence of violence, particularly around young children. And what this map does is really dispel that violence is, concentrated in only one corner of our state, but it actually is throughout our state in various parts. So now on to our REACH indicators. Now these are the public investments that the state makes to mitigate the risk factors that we just highlighted in the previous set of maps. And these are the 17 REACH indicators that were selected by the Advisory Council. But we, as today, will only be focusing on the health indicators there. And I really wanted to just also highlight that the two criterion is that they needed to represent a policy lever. That was one of the pieces that allowed us to select these REACH indicators, and they needed to correlate with mitigating the selected risk factors as well as, be available at a county level. So we'll take you through these particular maps. And as I mentioned earlier, the base of these maps, with the exception of some of them on our interactive data website, the base of these maps have the overall risk compiled score. And what you see here is, again, a heat map that takes all 15 of those risk indicators and gives a particular overall risk score to each of the counties based on the mean within each risk indicator, and then coming up with a mean score for each county. So this is the base of our REACH maps, and then the yellow dots are going to be representative of the public investments that reach the communities. So what you see here are the mental health services. And again, wanting to just give you a little bit more information about this. So this isn't even the whole universe of mental health services for children 0 to 5. This is the percent of children age 5 and under who received mental health services through All Kids. And so it's just that sliver of children. This was the best we can do with really seeing what publicly funded mental health services for children to 0 to 5 exist. And I want to point out that the biggest circle represents 26%, And, you know, I want to kind of just point out how these maps can be really helpful in helping us have some conversations about resource distribution. So, you know, the first circle was Warren and Knox and Fulton and Vermilion counties in the second circle. And what you see, you know, is there's some elevated risk and some services. But what you see actually down south in Franklin County is you have elevated risk and you have a decent level of services. And so that can really be instructive about what are they doing in Franklin County that we maybe perhaps can learn up north by the Wisconsin border in Winnebago and Stevenson County. So it's just ultimately, these types of maps are great for our policymakers to see at a bird's eye view, what is the distribution of resources and what can we learn from various parts of the state to figure out how we can align best with risk factors and then ensure that the provision of services meet the needs. So the next map is prenatal care. This is the percent of births with adequate or above prenatal care utilization. And what you will see here is the breakdown by race, ethnicity in terms of who had access to prenatal care. And then the dots that you see, they range from 65% to 95%. And you see what that distribution is across the state, with the state average of 74.3%. And we know that prenatal care can mitigate outcomes related to severe maternal morbidity, as well as the premature births. Child nutrition, this is the percent of income eligible children age 4 and under receiving WIC benefits. That's the Women, Infants, and Children Supplementary Nutritional Assistance Program. And what you see across the state is a range of reach from 8.51% all the way to 100%, and then varying levels of access across the race ethnicities. Now, with respect to immunization, and we know that this is going to be top of mind as we are looking to secure a vaccine for COVID-19, but the percent of children 19 to 35 months who completed the combined 7 vaccine series, the state average was 58.8%. And what you see is a reach level that ranges from 36.66% all the way to 85.72%. And we obviously have some work to do across the state, and I think particularly really important to message out to families to keep those well baby visits during this period, because pediatricians are still available to meet those needs, and they are fearful that actually children will fall off schedule because of concerns with COVID-19 and not wanting to take your children out. Lead testing. This is the percent of children age 6 and under tested for blood lead levels. And state average, we have 21.5%. And the reach level in terms of what the prevalence of testing is from 6.10% to 37.9%. And as you can see, again, the disparities with respect to who is being tested across the board. So now I'm going to just show you a couple ways that you can kind of like look at 2 different data indicators from the risk and reach report, comparing like a risk map to a reach map. This particular map was taken from the interactive data website, so you can really see it front and center. So the base of it, the blue, represents the prevalence of preterm births, and then the yellow dots is the reach indicator, and that represents the reach of prenatal care. So you can really kind of get a sense of how this particular risk factor is mitigated or not by the availability of adequate or above prenatal care. The same with maternal morbidity, the base map, you see the prevalence of severe maternal morbidity and you see the reach of prenatal care. And then you also see the breakdown by race, ethnicity, and what the different experiences are by race, ethnicity. Violence exposure, looking again at the distribution of violent crimes per 100,000 population, and then the reach of mental health services for children 0 to 5 through the All Kids program. So some key messages I want to just share is that risk factors are inclusive of the health of mothers and environmental conditions, as we had seen with the maternal morbidity and the violence exposure. They often affect Black, Latinx, and other communities at higher rates, and that Black and Latinx mothers had lower rates of prenatal care at 59% and 69% respectively. And just to say one more thing, you know, during the COVID-19 pandemic, there is actually some concerns with respect to how women are birthing during this period, particularly because there are much more provisions on limited external support when you're giving birth in a hospital. The telehealth for prenatal care can have some limitations. There has been some reporting of a pushing of inductions and C-sections to reduce the hospital wait time. There is an increase in breached babies due to decreased movement. And, you know, postpartum, thinking about the isolation of moms and the lack of support because we are under a stay-at-home order, and the increased potential of postpartum depression and anxiety. And so we will definitely need to be addressing those needs through policy with respect to the expansion of Medicaid and coverage of out-of-hospital births and recruitment and retention of additional healthcare workers who reflect the communities that are being served, and ultimately reducing these adverse maternal outcomes that are rooted in systemic racism. And so I know Mitch will be discussing that a little bit more through the fiscal portion of the presentation. So ultimately, you know, we need to have more rigorous and unified data collection, specifically around maternal morbidity, and then looking at that vaccination series. Only 18 counties have a high level of reach, so we definitely need to do some more work. So I'm going to pass this over to my colleague Mitch, who can go over the kids count report and the correlating data points, particularly as it relates to COVID.
Thank you very much. And as I start, I also want to give a shout out to our Kids Count project manager, Dr. Bill Burns, for his work on the Kids Count report, which will be out in the next few weeks. So if you go to the next slide, please. According to data from the Health Resources and Services Administration, in 2017, there were 47 Illinois counties that did not have any practicing patient care pediatrician. One persistent issue has been incentivizing young doctors to practice in underserved areas, including but not limited to rural areas. An element of that is patient caseload and the cost of medical malpractice insurance. There's also the consolidation of healthcare systems across the state. Now, this does not mean that children in rural areas don't get health care. Family practitioners still see and treat children. But this statistic is an important consideration when you consider, according to a 2016 study in the journal Pediatrics, rural children hospitalized at children's hospitals have higher rates of medical complexity and often reside in low-income and medically underserved areas. Compared with non-rural children, rural children experience more expensive hospitalizations and more frequent readmissions. Next slide, please. These are two maps showing the number of coronavirus cases as of Thursday. You can see the concentration in northeastern Illinois. And as you zoom in on northeastern Illinois, you can see the increased number of cases, particularly on Chicago's west and southwest sides. These areas are predominantly Latinx. In fact, statewide Latinx residents make up 28% of the confirmed coronavirus cases in Illinois, yet the Latinx portion of the state's population is just 17%. African Americans make up nearly 18% of the cases, but are just 14% of the state's total population. I want to add that of the total number of cases, 26% did not indicate their race or ethnicity. African Americans comprise 32% of the 3,928 deaths from COVID-19 as of Thursday, which again is in comparison to being just 14% of the state's population. So you can see the disproportionate impact when examined by race and ethnicity that the virus is having. These numbers are likely indicators of underlying health conditions and disparities in those conditions. And these overall trends are very likely reflective of circumstances faced by Illinois children and families. And it could have an impact in other ways. For example, according to a study by the Illinois Network of Child Care Resource and Referral Agency, in 2017, African Americans made up 34% of the workforce of assistants at licensed family care facilities in Illinois, and Latinx 30%. Next slide, please. So Voices for Illinois Children produced this slide for our upcoming Kids Count report, which will focus on children's health. Again, looking at the mid-April numbers on a per capita basis, you can see the higher number of cases on the south side of Chicago and south suburbs. On the left, that red area in the lower third of the state is Jasper County, where there was a coronavirus outbreak at the Newton Care Center. So the current coronavirus pandemic has demonstrated not only ethnic and racial disparities with regards to confirmed cases and fatalities due to the virus, but also accentuated the underlying health disparities within the state and nationally, leading to a greater susceptibility to the illness. Next slide, please. So we have a couple of recommendations in our report. These are just a few of them. But with respect to the data that we're showing you and how it's broken out by race and ethnicity, both in the preparation of the Risk and Reach report and our Kids Count report, we often didn't have county data that was available by race and ethnicity. And we believe that if state agencies collected more of this data, it would help in the analysis of the condition of children. So we are recommending that Illinois adopt legislation that expands to other state agencies, such as the Illinois Department of Children and Family Services, the Illinois Department of Health Care and Family Services, the Illinois Department of Public Health, the current state law that requires the Illinois Department of Human Services to collect and publicly report statistical data on the racial and ethnic demographics of program participants for each program administered by the department. In addition, we believe such agencies should also publicly report on the demographics of individuals residing in Illinois that are in need of or eligible for services provided by the agencies. Next slide, please. I also want to add for two of the other recommendations, the expansion of mental health services. In 2009, the Illinois Children's Healthcare Foundation embarked on an effort to establish community-based mental health systems in 4 areas of the state to better serve the mental health needs of children. Based on the foundation's evaluation of this effort, there was significant improvement in systems integration in the communities, and all 4 communities succeeded in dramatically increasing the number of children screened for developmental and mental health concerns. Also, 2 Illinois health entities in 2018 received grants from the Center for Medicare and Medicaid Innovation to establish integrated care for kids models. So we would encourage the state to fund more integrated models, combined with the establishment and participation of school-based clinics, to help identify potential behavioral issues in children and provide needed treatment. We also would recommend the expansion of telehealth services. In March, the Illinois Department of Health Care and Family Services amended state regulations to allow reimbursement of medically necessary and clinically appropriate telehealth services until the public health emergency declared because of the coronavirus pandemic no longer exists. We believe taking a look at that expansion and the effectiveness of telehealth counseling would be helpful. So now let's turn to the fiscal scan and where we are spending our dollars. Next slide, please. The fiscal scan and the risk and reach report covered a period that included the state's fiscal year 2019 appropriations and 2018 expenditures. Normally, reviewing those years would help in understanding the roadmap laid out for fiscal year 2021, even with some changes that may have occurred in the intervening time period. But we're just in a different environment now as a result of the coronavirus pandemic. For the current fiscal year, the state projects a loss in revenues of $2.7 billion that it is meeting through short-term borrowing, delaying repayments to the Treasurer's Office of Investment Funds, and delaying repayment of money secured from other state funds. A large part of that drop comes from the state delaying the filing date for state income taxes from April to July, just as the federal government did. But even when you go into the next fiscal year, which starts July 1st, you're looking at a revenue drop of more than $4.6 billion. That's including the delayed state income tax payments. Combined with having to make the payments on the bonds and to other state funds, the state is looking at a revenue shortfall of $6.2 billion if voters approve a graduated income tax in November, and $7.4 billion if they do not. All of that is without additional federal assistance, which could change the budget hole faced by the state. Legislators have been holding working group sessions by video conference and phone over the last several weeks. They are scheduled to return to the Capitol on Wednesday. However, it's not clear how the General Assembly will deal with the shortfall. So all of that said, it still is instructive to see how we've utilized state dollars for children's health over the years. Next slide, please. Just to remind everyone, the Risk and Reach Report's fiscal scan specifically looked at programs serving young children, age 5 and under, and their families. In cases where we could not parse out the data for a program based on that age range, we, as a general rule, did not include the expenditures in this report. An advisory group of advocates and funders met regularly to consider what items to include in the report. There are some items left out that we know have an impact on families, such as the state and federal earned income tax credit and Section 8 federal housing assistance. But I think what we settled on gives you a good idea of how we spend our dollars on young children. So this is a breakout of the major areas: family stability, health, and early care and education. And as you can see, healthcare makes up nearly half of the expenditures. Next slide, please. I also want to point out that while the total sum of expenditures on young children and their families may seem large, it represents less than 5% of the total operating budget, or it did in fiscal year 2018. Furthermore, nearly 2/3 of the funds we spent on young children comes from the federal government. We have cases in this report where the funds are labeled state funds because that's how the Governor's Office of Management and Budget designates them. But in reality, some of these funds contain federal funds that are transferred in during the course of the year. Next slide, please. So let's look at the health category overall. Again, I want to point out that a major category not included here is family care assists, because we could not break out the data for households with children age 5 or younger. The majority of funds spent here for health are spent by the Illinois Department of Health Care and Family Services. And if we go to the next slide, you'll see that 60% of the healthcare expenditures listed in this report are for the All Kids program, which provides health insurance to children. Now, this program includes money received for Medicaid, the Children's Health Insurance Program, and general revenue funds. For the most part, with Medicaid services, the state receives reimbursement of just over 50%. Next slide, please. Before we delve more into the All Kids program, let's take a look at the nutrition categories. These expenditures are largely for WIC and the Child Care and Adult Care Food Program, which provides reimbursements to child care centers, family and group daycare homes, preschool programs, and before and after school programs for meals and snacks served to young children. Now, not contained in the health section, but within the economic support section, is spending with reference to SNAP, which serves approximately 14% of the state's residents and accounted for $2.8 billion in federal expenditures to Illinois families in fiscal year 2018. During the pandemic, and I'll review some of the other measures later, the state has increased benefits to Illinois households enrolled in the program to the maximum level. Next slide, please. As we get into healthcare coverage for children, I want to begin with this chart from Voice's Kids Count report. This illustrates that nearly 40% of Illinois children receive healthcare coverage through Medicaid, which is incorporated into the All Kids program, or another means-tested public program. Overall, more than 96% of Illinois children had healthcare coverage in 2018. But I also want to note that between 2016 and 2018, there was an increase in the number of uninsured children. Now, this uptick could have occurred for a couple of reasons. In 2017, the federal government repealed the individual health insurance mandate penalty. There was also delayed extension of the Children's Health Insurance Program, fewer available resources for Affordable Care Act outreach and enrollment efforts, and there were debates about immigration and public charge. It should also be noted that in 2017, Illinois experienced problems with approval of Medicaid applications. That includes redeterminations, as it began to use a new computer system. Next slide, please. Now, if you look at the rate of toddlers on Medicaid at 42%, it's even higher than that for children up to age 19. The group of toddlers on Medicaid, the percentage of African American and Latinx toddlers on Medicaid is higher than the statewide average. The bottom line of these two charts is that the All Kids program plays a significant role in the health of young children, and particularly children of color. Next slide, please. So what do we get for our money? Well, the majority of expenditures are for inpatient services. But what I really wanted you to take away from this chart is the relatively low percentage of funds spent on mental health and dental services. Now, to view this chart properly, you also need to take into account a shift in the operation of the All Kids program. In 2011, the Illinois General Assembly approved legislation which required at least 50% of the individuals eligible for health care and family services medical benefit programs to be enrolled in a care coordination program by 2015. Then in 2016, HFS put out a request for proposals to expand the MCOs. And as of today, 79% of the children participating in the All Kids program are enrolled in MCOs. Next slide, please. And the MCOs conduct survey results that are then reported to the state. And it's these two categories that I want to draw your attention to, in which in all but one instance for one MCO, the entities are ranked at the lowest performance level possible compared to national standards for children under Medicaid getting needed care and getting care quickly. Now, again, these are survey results, which is measuring perception, but these results should be of concern to everyone. So to draw the line to the last few slides, a significant portion of the state's children are receiving health care coverage through the All Kids program. a larger portion of them children of color. A majority of the all kids enrollees are in MCOs, and survey results indicate a potentially low level of service or performance. So one of the other recommendations in our upcoming Kids Count report on health is that the state delve into these numbers in much greater detail to see what's occurring with regards to the availability of care. I also want to point out that according to the National Survey of Children's Health, 43.9% of African American children have a medical home, which is a medical practice organized to produce higher quality care and improve cost efficiency. That's in comparison to 58.3%. So that's a consideration, again, with the delivery of healthcare. Next slide, please. HFS also runs a program to assist pregnant mothers called Moms and Babies. The state spent $247 million on the program in 2018. And an important component of this program is that you do not need to be a citizen or legal immigrant to receive coverage. As a general rule, undocumented immigrants are not eligible to enroll in Medicaid or to purchase coverage through the Affordable Care Act marketplace. So we need to recognize also that of the federal benefits approved during this pandemic to help individuals across the country, many of them are unavailable to undocumented residents. Next slide, please. Prenatal services are also delivered to the maternal and child health services provided through the Department of Public Health and the Department of Human Services. This chart looks at the breakout of those programs, but in particular, I wanted to point out the expenditures on infant mortality. Next slide, please. So as you're probably discerning now, it's not just a question of how much we spend in a particular area for a health-related purpose, but how we're allocating those dollars and whether it's addressing the needs. And while the majority of expenditures in the prior chart was to address infant mortality, we have to recognize the fact that the infant mortality rate for African Americans is significantly higher than the statewide average. In fact, the ratio of African American infant deaths to white deaths has been higher than the national average for all but one of the last 10 years. The General Assembly did approve legislation last year creating a task force on infant and maternal mortality among African Americans. That task force is to report its findings and recommendations to the General Assembly by the end of this year. And I also want to say that while the Risk and Reach report has concentrated on a variety of state healthcare expenditures, we need to ask what role do county and municipal health departments play with regards to the healthcare coverage of children, and also what revenue streams are available to them, such as property taxes. Next slide, please. Just as with SNAP, in another category of the Risk and Reach report, I did want to note that home visiting expenditures, which totaled $24.6 million in fiscal year 2018, are in the report under early care and education. The state's home visiting programs are designed to improve maternal and child health. And in January, Governor Pritzker announced his intention to boost home visiting programs by 2/3 between now and 2025. Again, what will occur going forward will depend on the state's overall financial picture, which includes the availability of federal funding. Next slide, please. So that brings us to our current point in time. Normally in these deep dives, this is where I would talk about progress since the issuance of the Risk and Reach report, but it's just a completely different environment now. The national unemployment rate for April was 14.7%, with a greater impact on Black and Latinx families. As a result of job losses, some 27 million Americans may lose health coverage, according to the Kaiser Family Foundation. And food banks are seeing dramatic increases in the need for food, along with immediate needs for assistance in housing and with regards to paying utility bills. Next slide, please. Here are some of the measures already approved by Congress. They include increasing the FMAP, or essentially the reimbursement rate from the federal government for Medicaid and several other programs. The loss of health insurance for many Americans likely means we'll see a surge in Illinois Medicaid applications. Congress also appropriated additional funds for WIC, food banks, and has taken steps to prohibit any cost sharing under health plans for coronavirus testing. But there is more to do. We can go to the next slide, please. We could increase the federal matching assistance percentage by an additional 5.8% to help meet demand. We could increase SNAP benefits and provide greater assistance in direct financial aid through some type of package. This box at the bottom shows elements of a relief package that Democrats in the U.S. House have put forward. It contains $500 billion for direct aid to states, $100 billion for low-income rent assistance, $75 billion for COVID-19 testing, and some other measures are also in there. And then if you go to the next slide, I would be remiss if I ended this presentation without urging you, your colleagues, and those you serve to complete the U.S. Census form. For all the areas we have referenced today, as well as others, the census has a tremendous impact with respect to how much money may flow to the state of Illinois in the next decade, not just for healthcare, but also for housing, education, and nutrition. So with that, I will turn it back over to Cristina.
Thank you, Mitch. Just wanted to close us out, reminding everyone that you can access the physical report for Risk and Reach, the physical fiscal scan report, as well as the interactive data through the riskandreach.erikson.edu website. There, you can download the reports, the county one-pagers. You can see a short video that explains the purpose of the report, and you can also see how the report has been covered in the media. If you have any questions, please send us a note at policy@erikson.edu. If you are interested in having a presentation in your community, we would be happy to provide that, and you can make that request through that email address. And the last piece that I want to just highlight is that you can get all of the information with respect to our policy and leadership initiatives at Erikson through a free app. You can download it through Google Play or the Apple App Store, and you will be able to have access to the Risk and Reach data as well as all the other initiatives that are coming out of Erikson with respect to policy and leadership. So thank you very much for joining us this afternoon. We will be sending this recorded webinar to all of the registrants along with any supplementary resources that were provided. And we look forward to hearing from you and your questions as well as inquiries for any type of presentations. Thank you.